Yep. And being recorded.
Starting caregivers in the field and their responding times.
Okay, so this week we're going to really dive into the arterial circulatory system, the vessels, the major vessels that we image and ultrasound. So this is just, kind of a general overview map of, some of the arteries within the body. I kind of just put this up to just bring home the point of proximal versus distal. So if you drew the patient's heart right here, so this is your thoracic aorta, proximal ascending aortic arch, descending thoracic aorta. So the patient's heart is situated right here. So you have to use the heart as kind of your landmark, your home, and everything is either proximal or distal to each other in relation to that heart, how far away you are from the heart. So if I was to for example, look at two vessels, say I take subclavian artery and then brachial artery in the arm. Subclavian artery would be described as proximal to the brachial artery. The brachial artery is more distal because it's further away from that heart if you kind of think of it as a road. So use the heart as your home base, and these are roads leading away from that heart. So the further you are away from that heart in that road, the further you've traveled away from home, you are more distal. So you can look at two vessels and compare them to each other as being proximal or distal. So radial artery would be distal to the brachial artery, radial artery down here in the arm. If you look at the legs, common iliac artery would be proximal to femoral artery in the thigh. Femoral artery would be proximal to popliteal artery. Posterior tibial artery down in the leg would be distal to popliteal artery, would be distal to femoral artery, would be distal to iliac. So you have to just use the heart as your home when you want to determine what is proximal and distal to each other. It's important because when we start imaging, we image segments of vessels. So we're going to be imaging, the brachial artery. You're going to have to do proximal brachial artery, mid brachial artery, and then distal brachial artery. So as you're imaging and labeling, those labels are important because the doctor needs to know, are you at this segment, or this segment, for that brachial artery? Are you proximate or distal? So that's how the whole proximate distal, works when you want to describe vessels. All right, so central arterial anatomy. So when we're talking about central arteries, these are the major vessels and the branches off the abdominal aorta. So the abdominal aorta is going to be your main central artery. And then we're going to discuss the major branches off of that abdominal aorta. So for this class, we image the abdominal aorta. CVS will image a lot the thoracic aorta coming off the heart. That's more their focus. But for this class, we're going to be looking at the abdominal aorta. So the major branches off the abdominal aorta are going to be the celiac artery, the superior mesenteric artery, the renal arteries, and then the inferior mesenteric artery. So this is kind of going in sequence from superior to inferior. So if you just envision your abdominal aorta coursing, your first branch, the first most superior branch is your celiac artery. So you might see celiac artery also written as a celiac access or celiac trunk. So all those vascular, you're going to see there's multiple names for the same vessel. I don't know why, drives me nuts, but You can see it in text, some patients or some doctors describe it as celiac artery. Some people describe it as the celiac trunk, some people describe it as the celiac axis. So coming down, the next vessel that you're going to encounter as you come inferior is going to be your SMA, the superior mesenteric artery. Then you'll encounter the renal arteries just below that. And then further down, mid-distal abdominal aorta, you're going to encounter the inferior mesenteric artery. In terms of liver vasculature, some of the vessels that we're going to image are going to be the hepatic arteries, the portal veins that bring blood into the liver. So both of those bring blood flow into the liver. And then drainage for the liver is going to be the hepatic veins, and those drain into the inferior vena cava. So in terms of the abdominal aorta, it's the major blood supply for the digestive organs. It's responsible for bringing blood flow to the kidneys, the adrenal glands, the gonads, the abdominal and perispinal musculature, the pelvis, as well as the lower extremities. The abdominal aorta lies just to the left of midline in the patient. So if you picture the patient lying on the table, you draw a midline right down the middle of their body. It lies just to the left of midline. It starts to taper distally. So the further you get away from the heart, the more distal you go, it tapers a little bit. So that diameter is not as wide as it is more proximal. Around the level of L4, level of the umbilicus, is where it splits or bifurcates. So when you hear that term bifurcation, that's an artery splitting or branching. So it bifurcates into the common iliac arteries. So in terms of normal diameter, so these are measurements that you're going to need to know for board exams and for me and forever going on forward. So for the abdominal aorta, less than 3 centimeters is considered normal. So once you get over 3 centimeters, that aorta is then considered aneurysmal. So it's dilated, it's aneurysmal. So anything over 3 centimeters is aneurysmal. Under 3 centimeters, you're good. In terms of the bifurcation, so we said it bifurcates into the common iliac arteries. So the common iliac arteries should be less than 1.5 centimeters. So if you think about it, this is still pretty small. 3 centimeters is pretty small. So I mean, that's like a little bit more than an inch, inch is 2.2 centimeters. So this giant major vessel, it's not large in the grand scheme of things. And then the iliacs, we said the bifurcation should be less than 1.5 centimeters. If it's over that, then the iliac artery should be considered aneurysmal as well. So this is just a nice diagram just showing the aorta. So this part, you can see the thoracic aorta, the aortic arch, so coming off the left ventricle of the heart. You have your ascending thoracic aorta, aortic arch, and then the descending thoracic aorta. Here we have the diaphragm. So that diaphragm muscle is what separates our two body cavities, the thoracic cavity from the abdominal cavity. And then once we cross past that diaphragm, we're now in the abdominal cavity. So this is not showing the abdominal aorta. So up here is your diaphragm. And then you can see your first branch, like we said, is the celiac artery or celiac axis or trunk. Coming down more inferior, your superior mesenteric artery. And just below that, you have your right and left renal arteries branching off. And as you work your way further down, you get your inferior mesenteric artery coming off the aorta. And then you're branching into your right and left common iliac arteries. So these are the major branch vessels. There are, additional smaller branches, coming off. So things like the lumbar arteries, that, we really don't image on ultrasound. Just part of the reason being they're very small. Oftentimes they're obscured by bowel gas. So here we see a nice sonographic image of the normal abdominal aorta now. So this is a sagittal or longitudinal view of that abdominal aorta. And then this is in that transverse view where we see the vessels as our circles. So with that anterior view, we can see some of the branch vessels coming off. So this arrow is pointing to the superior mesenteric artery. We can see the celiac artery coming off above it as well. Transverse, we don't see any branches coming off. So I forgot to mention too with the abdominal aorta, in addition to tapering, as you work more distal, it also moves more anterior. So if the patient's lying on that stretcher supine, the proximal aorta is going to be deeper. It's going to be a little bit harder to image sometimes. And as you come down the aorta starts to move more anteriorly, so more towards the surface of the skin, and becomes a little bit easier to image sometimes. So oftentimes the mid and distal aorta, much easier to see than that proximal segment. Sometimes you can utilize the liver to help you, sometimes not, but it also runs more anteriorly as you move more distally. In terms of the Doppler waveforms for the abdominal aorta, the waveform characteristics will change depending on where you are in that abdominal aorta. So above the level of the renal artery, so that proximal segment or mid segment, above the level of the renal arteries, you're going to see more diastolic flow. So if you see more diastolic flow over here, that means it's a lower resistant waveform. The reason we have more diastolic flow is because at this point, a lot of that blood flow is going to vital organs. So that celiac artery branches into hepatic artery, splenic artery. It's bringing blood flow to the liver, to the spleen. We have the renal arteries that are still branching off. So blood flow is going to the kidneys. So we need that continuous forward flow going to these vital organs. So that's why we see more diastolic flow above the level of the renal arteries. So this is, a monophasic, lower resistant waveform. Below the level of the renal arteries now, the majority of that blood flow now is destined for the legs. So that's going to be a higher resistant vascular bed and doesn't need that constant flow all the time. So we see a higher resistant waveform and a triphasic waveform represented. So it's much less diastolic flow. We can get a triphasic waveform below the level of the renal arteries. So above the level of the renal arteries, it's a lower resistant waveform. Why? Because that blood flow is destined for the organs, or a lot of that blood flow is destined for your vital organs. Whereas below the level of the renal artery, the blood flow that's remaining is primarily destined for your lower extremities, for the legs. I'm just going to talk a little bit about the major abdominal aortic branches now, each one specific. So celiac artery or trunk, we said, is the most cephalid or most superior branch off the abdominal aorta. It arises off the anterior surface of the aorta. So if I picture myself in a line there on the table, the anterior surface is going to be kind of coming straight out at you, the anterior surface of that aorta. It trifurcates or branches into three different vessels. We have our common hepatic artery, the splenic artery, and the left gastric artery. So in terms of ultrasound, we don't typically image the left gastric artery too often, but we are always visualizing, those two. It's quite common to image, or it's part of a lot of protocols to acquire images for your common hepatic and splenic arteries. So to best visualize the hepatic artery, you're going to be in a transverse plane, and you're going to see two branches. You're going to see both of these branches that have common hepatic and the splenic artery, and they're going to present themselves as in a T formation. Sometimes this is referred to as a seagull sign, because each branch looks like the wing of a bird. So again, both these vessels are bringing blood flow to an organ, so they should be low resistant flow patterns. So here we can see an ultrasound transverse view. Now we know we're in transverse to that vessel because we see the aorta as a circle, inferior vena cava as a circle. So this is that celiac artery coming straight up at us at the transducer. So my probe is up here on the front of the patient, and I'm imaging straight down on that celiac artery. So it's coming up towards me, and then I can see my two branches. So going towards the patient right, towards the patient's liver, is going to be your common hepatic artery. Going out to the patient left, towards the spleen, is going to be your splenic artery. So those are your two branches of your seagull sign there. Then in terms of the waveform, it's a very low resistant waveform. We see a ton of diastolic flow in both the common hepatic and splenic artery waveforms. So those are both nice, low resistant, healthy looking arterial waveforms. The celiac axis has a nice low resistant waveform. Now moving down inferiorly, the next branch that we're gonna encounter is the SMA, superior mesenteric artery. Again, this also arises off that anterior surface of the aorta, so it comes out directly anterior. The SMA supplies the jejunum, ilium, cecum, ascending colon, proximal 2/3 of the transverse colon, a portion of the duodenum and the pancreatic head. So basically think of the SMA feeding the majority of the right side of the intestine and the transverse colon. So all the intestines and gut that exists on this side of the body up to midline coming across is going to be all SMA. So you have your ascending colon, your transverse colon, your portions of your small intestine on that side, the pancreatic head, all supplied by the SMA. SMA is unique because it has this distinctive triangular mantle of fat that surrounds the vessel that creates almost like an echogenic or a very bright halo around the vessel that makes it easily identifiable compared to some of the other arteries. In terms of relational anatomy, it lies the pancreas and the splenic vein lie anterior to this vessel or in front of this vessel. The left renal vein lies posterior to this vessel. The flow pattern. So near the origin, it could appear kind of turbulent. But with the SMA, it has a unique property where the resistance of that waveform will change depending on whether or not the patient is fasting or they've just eaten. So this term preprandial means that the patient is fasting, they haven't eaten anything. Postprandial means that they've just eaten or consumed something. So this is fasting and then non-fasting or after a meal. So if the patient is fasting, they haven't eaten in a long time, your intestines aren't working. There's no need for that blood flow to go to your intestines for digestion. So the body's going to conserve some of that blood flow, send it somewhere else where it's more necessary. So that waveform is going to have a higher resistance to it, or a higher resistant flow pattern. After you've eaten, your body needs to digest all that food, get all that nutrients. So it's going to divert more blood flow to your intestine for digestion. So now that SMA is going to exhibit a lower resistant flow pattern. The body wants to bring that blood flow to the intestine for digestion. So it's going to release, those smooth muscle fibers, their vessels are going to dilate, and it's going to allow for more diastolic flow to get to that, to the intestines to aid in digestion. So you're going to see that in your waveform as a lower resistant flow pattern, more diastolic flow. So here you can see the SMA and its flow patterns, the vessels that it feeds. Oh, the top's falling off. Doesn't work. I had Brian up here last year. He was like the perfect size. He stood up here and lined up perfect with his aorta, and you could see it kind of just all feeding, the vessels on that side. I don't know, am I lined up? Not really, but need someone taller. Who's tall? Want to come up here, Hunter? Yeah, but you can appreciate, so it feeds, like all the intestines on this side. So you got your ascending colon, transverse colon, portion of your pancreas, your duodenum, your jejunum. We'll see the IMA now is going to feed the left side of the intestine. So this is going all towards the patient right. The IMA, which is further down, is going to feed the descending colon, rectum, so that the more distal portions of your intestine. In terms of ultrasound, so we said it's distinctive because it's surrounded by that echogenic triangle mantle of fat. So this is a transverse view now. So your superior mesenteric artery is this vessel right here. So here's your aorta. It rises off the anterior surface of the aorta, so you're going to see it more anterior. So in terms of relational anatomy, this is anterior, posterior. So we're scanning through the patient's, anterior surface. So your SMA is going to be surrounded by this echogenic mantle of fat. So you see it very distinctive and transverse. Almost looks like a target or a bullseye of the SMA. Some of the other vessels that you can see here, this is splenic vein, the pancreas. So they're both anterior to that vessel. You're not really seeing it here, but the left renal vein, of course, is posterior to the SMA. So it's going to be coursing from the left kidney out here behind the SMA and between the aorta, getting out to that IVC. Well, we're going to study that more in detail when we get into some of the other abdominal classes. In sagittal, again, you can see your aorta coursing up and down. We have a longitudinal or sagittal view of that aorta now. And again, the SMA rises off the anterior surface, comes off the anterior surface, and then runs inferiorly. So it kind of parallels the aorta. So it's easier to identify as it coming off and then running inferiorly and paralleling. So in terms of orientation, this is towards the patient's head. That's going to be superior on this side of your screen. This is going to be inferior down towards the patient's feet. So in this case, blood flow is going in this direction, down towards the patient's feet. And then aorta, the SMA blood flows following that orientation. In terms of SMA Doppler signals. So you can look at the two Doppler signals here. So that first one is demonstrating a high resistant, flow pattern. It's much less diastolic flow compared to this one. It's actually triphasic. So this would come from a patient who's fasting. So this is normal for someone who's fasting. That's what we'd expect. And then after the patient's eaten, so this is postprandial, we can see that there's much more diastolic flow. This is a monophasic lower resistant waveform. So this is what we expect. This is normal. This is physiologically, what we expect to happen. Third vascular class, when we get into abdominal Dopplers, we'll understand, if we see deviations from this, what it could potentially mean, some of the medical conditions that you could be seeing if you, aren't able to elicit this response, with the patient eating. This was showing, another SMA. Again, nice, healthy looking waveforms. In terms of renal arteries, so the renal arteries now, they arise off the aorta slightly below the level of the SMA. So typically it's about 2 centimeters, 1 to 2 centimeters below the level of SMA, where the renal arteries will come off. In terms of relational anatomy, they lie posterior to the veins. So if they're coursing through the body, the veins will be above or on top of the arteries. In order to see the renal arteries on ultrasound, they're best seen in a transverse view. If we come midline on the aorta, since they come off laterally, you need to be in transverse to be able to see those branches coming off. The right renal artery comes off a little more anterior. So it's the anterolateral aspect of the aorta. And then courses posterior or behind the IVC. And is longer in length than the left renal artery. So if you just kind of think about it just intuitively, aorta is sitting on the patient's left, slightly to the left of midline. The right kidney is all the way out here. So that right renal artery has to cross midline and get to that right kidney. So it's going to be longer than the left renal artery, which doesn't have to, go all the way past midline, just has to get to that left kidney. So left renal artery is going to be shorter in length compared to the right. In terms of the left renal artery, this one typically comes off a little posterolateral, so it's a little bit more posterior, whereas the right renal artery comes off a little more anterior. So it's still the lateral aspect of the aorta on each side, but one is a little more anterior, the right, and the left is a little more posterior. In terms of the branching patterns for the main renal arteries, so the main renal artery comes off the aorta. Once you get into the kidney, the main renal artery will branch into the segmental arteries. The segmental arteries then branch into the interlobar. The interlobar arteries then branch into the arcuate arteries. And then the arcuate arteries then branch into the interlobular. So we'll go into definitely more detail when we get into our abdominal vasculature class. There are anatomical variants that do exist. So we'll learn eventually about anatomical variants that we could encounter. And then in terms of flow pattern, again, blood flow is going to a vital organ. The kidneys are vital, so it has to be a nice low resistant flow pattern. That's what we like to see, or we expect to see. So this diagram shows you, the renal arteries and their relation. So you can see that right renal artery coursing behind or posterior to the IVC. So the IVC is actually running in front of the right renal artery. So that's your normal anatomic orientation. So we can see that on ultrasound as well now. So now we're in that transverse view to try and visualize the renal arteries. So I'm lying here in transverse, I see my aorta, right middle artery coming off anterolateral, so a little anterior and lateral. Course is posterior to your IVC, so we're behind the IVC, going out towards that right kidney. Coming off your IVC is gonna be your right renal vein, so this is actually blood flow draining from the kidney through that right renal vein and dumping into your inferior vena cava. So we said the vein is anterior above the artery, so this is nice, normal, anatomic, orientation. So on the left side, we can see now we have our aorta, again, transverse, left renal artery, so this one's a little more posterior. So instead of coming off the anterior aspect of the aorta, this one, the left one's a little more posterior, still lateral though, going out towards the patient's left. And then that left renal vein, again, is anterior or above the artery. So that's your normal presentation with the vein anterior to the artery. So over here, even though it's not labeled, you see that echogenic mantle fat creating kind of like a target or bullseye. That's going to be your superior mesenteric artery there. So you can see the SMA there. And then this is a good image showing that left renal vein coursing in between your SMA and your aorta. So in terms of your renal branching patterns, so we said we have the main renal artery coming from the aorta, branching into your segmental arteries. So main renal artery branches into your segmental arteries. Those segmental arteries, once they're into the kidney, then branch into your interlobar. So one of the ways I remember is the kidney is, when you start learning about the kidney, is broken down into segments or poles. So we have an upper pole, a mid pole, and a lower pole. So I think of these as lobes of the kidney. So we have an upper lobe, a mid lobe, and a lower lobe of the kidney. So this interlobar artery runs in between the lobes of the kidneys. So main renal artery branching into your segmentals. And then from the segmentals, it's arteries that run in between the different lobes of the kidney. The next branch that gets a little bit smaller then, those interlobar arteries branch into your arcuate arteries. So we start learning about the kidneys and the structures. These are what are called the pyramids within the kidneys. This is where the filtration occurs. The arcuate arteries do this kind of hook turn and run over the anterior aspect of or the outer aspect of your kidneys. I'm sorry, the pyramids. These are going to be your arcuate arteries. And then the small little arteries that are out in the outer portion of the cortex of the kidney are your interlobular. So this is one of the branching patterns that eventually you're going to just have to be able to memorize cold. In terms of the renal artery and vein, the Doppler waveforms that we expect to see. So kidneys, 100% should be a nice low resistant waveform. So lots of diastolic flow, continuous, forward flow throughout diastole. Again, we look for a nice fast upstroke, nice fast downstroke, a lot of diastolic flow. Again, so tardius parvus would be bad. So if we were, Dopplering and we see a very delayed or slow upstroke, that could potentially indicate our tardius parvus waveform. And that would indicate that we have a more proximal stenosis. So that would be something that we look for, particularly when we're assessing the kidneys and the renal arteries. With the renal vein, there should be phasicity to it. So we should see some of those rolling waves, the ups and downs with our respiration. So that's, again, nice, healthy waveform. So we see that phasicity, that phasic flow. Eventually we're going to learn about anatomical variants. So this was showing a patient that actually has 3 renal arteries coming to their kidney. So it's a little hard to see, but this is the patient's kidney, the outline of the kidney. And then you can see the vessels coming off. The patients can have duplicated renal arteries potentially. So, and then the last major vessel coming inferiorly now is going to be your IMA, inferior mesenteric artery. So this is midway between the renal arteries and that aortic bifurcation where it splits into the common iliacs. So this vessel provides blood flow to the distal colon and the proximal rectum. So this is the distal, segment of the large intestine. In order to locate this vessel, you have to head inferior and you're kind of oblique and an oblique angle. So not quite transverse, not quite sagittal. And it comes off anterior and slightly lateral and to the left. So this one's going to be a little bit tricky to find on ultrasound. It's something that we're going to practice that third semester. In terms of the flow pattern, so it's very similar now to your SMA in terms of your flow pattern. So it's going to change depending on whether or not, again, the patient is fasting or they've just eaten. So if they're preprandial and they're fasting, it's going to be high resistance. And if they're postprandial and they've just eaten, then it's going to represent a low resistant flow pattern. So this vessel is very small. So this is a transverse view showing aorta and IVC. And it's a small little circle that's kind of off to the side there. So it is a little bit challenging to locate and find an image. Particularly if you have patients, that are obese, have poor imaging characteristics, maybe they have a lot of bowel gas, this vessel could be quite challenging to locate and find and be able to image. So with this, it's a normal high resistant flow pattern in their fasting patient, and it gets lower resistant after they've eaten. So in terms of aorta and IVC, so this is now just showing aorta and IVC in relation to each other. And then your major branch vessels, so your abdominal aorta to the patient left, IVC to the patient right. So you have your celiac artery or trunk, SMA, your renal arteries. So, left renal artery, right renal artery coursing behind the IVC. Inferior mesenteric artery, your common iliacs. So common iliacs also then branch into internal iliac and external iliac. So this was just showing, so now cross-sectional anatomy, the descending aorta as we're coming down. So you can see, so now this is starting more proximal, higher up in the abdomen. So you can see how far back that aorta actually is within that patient. So this is the patient's spine here. So it's all the way back near the spine. It's very deep as we're proximal. As we start running more, as we start coming more distally, that aorta starts to slowly migrate more anterior. That's where now we're getting down towards the level of the renal arteries. So here's aorta now coming down. And then as we get down towards the bifurcation, it starts coming a little more superficial. But you can really appreciate better like on the cross section. So aorta is there. And as you're coming down, it starts coming a little more anterior. It's as you get more distal. So these are showing some angiograms. So in terms of vascular, angiograms are going to be your gold standard for in terms of imaging vessels. So angiogram provides a very clear, detailed picture of all the vessels, all the branches, all the small little collateral. So you get a very nice picture with an angiogram. So we're going to learn about angiograms, what they actually are. But unfortunately, this involves, administering contrast agent to the patient and utilizes X-ray. So there's ionizing radiation. So you don't want to do this all the time. But it is considered our gold standard, what we compare our ultrasound to, in terms of how effective we are with ultrasound. So it's just showing again some of the branches of the vessels. Liver vasculature. So for the liver has a dual blood supply. So there are two blood vessels that are bringing blood flow to the liver. We have the hepatic artery and the portal vein. So the hepatic artery brings about 20% of the blood or the liver's blood supply. So it supplies about 20% of blood flow going to the liver. The hepatic artery supplies oxygen-rich blood for the liver. In terms of the hepatic artery, in its branches, it starts with the common hepatic artery. So that was that first branch off the celiac. The common hepatic artery then splits and branches into your gastroduodenal artery, GDA, and then the proper hepatic artery. So this is the one that ultimately, has its final destination in the liver. So common hepatic artery is that first branch off the celiac. That common hepatic artery then splits and branches into your GDA, gastroduodenal artery, and proper hepatic artery. This one, eventually supplies duodenum and portions of the stomach. Proper hepatic artery continues on and goes towards the liver. So in terms of flow pattern for the hepatic artery, again, it should be low resistant. And then there's a term hepatopedal. So this term hepatopedal means the ending pedal means that the blood flow is going towards the liver. So we'll see in a moment when we see the hepatic veins, that's going to be referred to as hepatofugal, meaning that blood flow is flowing away from the liver. So anytime you see this term pedal, it's going to mean towards with this term hepatic. So hepatopedal means blood flow towards the liver. So that's how we describe the flow direction in this vessel. Hepatopedal means blood flow towards the liver. I guess I think Miss Powell does this whole demonstration or analogy of like you're riding a bicycle and you're pedaling towards the liver. So when you see pedal or pedal, it means you're pedaling towards it. Portal vein now supplies about 80% of the blood volume that's going towards the liver. So again, the vast majority of blood flow going to the liver is going to be via the portal vein. This vessel supplies nutrient-rich blood from the digestive system and brings that to the liver. So the origin of the portal vein is from the coming together of the splenic vein and the superior mesenteric vein. So both of these veins come together. So it's two streams coming together to form a larger river, which is that portal vein. So the coming together or union of the splenic vein and the superior mesenteric vein form the portal vein. Portal vein brings that nutrient-rich blood to the liver. So in terms of flow pattern, this is a vein now. So it's going to be monophasic. It's going to be low velocity, but the flow direction should be hepatopedal, should be towards the liver. So with the portal vein, flow will increase in this vessel after the patient's eaten. So this is taking all the blood flow after the body has digested, the food and the nutrients in the intestine, and bringing that blood flow to the liver, for processing and storage. So after you've eaten, there's going to be more blood flow because the intestine's done its work, and it's bringing all that nutrient-rich blood to the liver at this point. So after eating, flow volume should increase. So this was just showing the hepatic artery and its branches. So we have our celiac artery, again, coming off the aorta, branches into your common hepatic artery. That common hepatic artery then splits into your gastric, your GDA, gastroduodenal artery. You also have a right gastric artery that comes off, and then your proper hepatic artery, which continues towards the liver. That proper hepatic artery will enter into the liver in an area referred to as the porta hepatis. That's where the vessel enters, and then will split into your right and left hepatic arteries. So you do have two branches of that proper hepatic artery. So once it splits in the liver, it goes to different segments of the liver. One going to the left lobe of the liver, and another feeding the right side or the right lobe of the liver. So this was ultrasound showing the hepatic artery near the porta hepatis, so the area where the blood vessels enter into the liver. So here we can see HA is the hepatic artery. This is your bile duct or your common bile duct, your CBD. So we're here near where the vessels are entering in. So this is going to be your portal vein, your PV. So you can see them both red, meaning that they're both flowing in that same direction, which is gonna be towards the liver, pedal. That's the flow direction that we expect to see. Your normal hepatic artery waveform should be a nice low resistant flow pattern. Excuse me. Your portal vein anatomy. So we said the portal vein was formed by the union or coming together of two vessels. So here's gonna be your main portal vein or your portal vein, and it's formed by the coming together of your superior mesenteric vein, your SMV, and your splenic vein. So here you can see the spleen out to the patient left, splenic vein coming in. A vessel that joins that splenic vein is your inferior mesenteric vein. So this is draining, the left side of the descending colon, the rectum. So we said with the inferior mesenteric arteries bringing blood flow to those segments, we need a drainage for those segments, and the drainage is going to be the vein, the corresponding vein. So the inferior mesenteric vein now is draining that portion of the intestines, bringing that blood flow. It joins into the splenic vein. Splenic vein that continues for a little segment, and then joins the superior mesenteric vein coming up that was draining now the right side of the intestine, the ascending colon, transverse colon, the duodenum, the jejunum. So all those intestines on that side of the body are being drained. So those two come together, splenic vein, superior mesenteric vein, and form your portal vein. Portal vein then enters the liver again at the porta hepatis, and then branches into a right and left portal vein once you're inside the liver. So you can see it again over here on this side. So SMV, splenic vein come together, form portal vein, courses up towards the liver. So it enters the liver, somewhere around here. So if we were to put a liver over that, then that portal vein branches into a right and a left portal vein. So in terms of you guys, labeling your anatomy, this is a good diagram to be able to label if you want to practice. So these are the major vessels that we're gonna, be responsible for in imaging. So portal vein and its tributaries. So in terms of the portal vein, we said again, there's two branches or two vessels that come together to form that portal vein, or two tributaries or rivers that feed into it and create that vessel. So for ultrasound, we're gonna be imaging those tributaries. We're gonna be imaging the portal vein. We can figure out, what it is we're looking at based on, which scan plane that we're in. So this was showing now the main portal vein entering into the liver. So we can see the main portal vein. Looks like I'm seeing a branch for the right portal vein. I'm not quite seeing the left portal vein as it branches, but here is the porta hepatis. So I'm seeing some liver tissue here, and it's entering into the liver at the porta hepatis there. So here we're further outside the liver near the pancreas. So in transverse, we see splenic vein coming into the portal vein or draining into the portal vein, creating it. In a sagittal orientation now, we see the portal vein with the superior mesenteric vein. So the way I know that I'm in sagittal or transverse, if it's not labeled on your image, I look at the aorta and the IVC. If the aorta and IVC appear as, circular structures, I know I'm in a transverse orientation. If I see it elongated or opened up across my screen, I know I'm in a sagittal orientation now. So if I kind of go back to this picture now, for your superior mesenteric vein and splenic vein. So if I have my probe in transverse, where I'm seeing, the aorta and IVC as circles, my transducer is going to be like that. I see that portal vein, so the piece of that portal vein, and I see that splenic vein coming across that way. So I'm able to see the structures forcing that way. So that's my orientation. When I turn it sagittal now, what I'm seeing now is the portal vein, and I'm picking up that superior mesenteric vein in sagittal now. So that's what I see when I see it in that screen. So that's kind of what you're seeing here. So in transverse, when I'm like that, I'm seeing the portal vein and the splenic vein going out that way. When I'm in sagittal now on that patient, what I'm seeing is a piece of that portal vein, but what I'm seeing now is that splenic vein coursing up and down. So it's going to take a little bit of time to kind of get used to how you visualize and how you see this, but that's how you understand, what you're imaging and what you're seeing. All right. So in terms of liver vasculature, so any structure, blood flow going in to an organ has to have blood flow coming out. So again, vessels bringing blood flow to the liver where the dual supply of hepatic artery and portal vein. So we need to now have a drainage for that organ, and that's via the hepatic veins. So hepatic veins drain blood flow out of the liver. So in terms of flow, this is now hepatofugal. So that ending fugal means away from, or flow away from the liver. So hepato or hepatic, that prefix, refers to the liver, hepato, and then fugal is going to be away. So this is blood flow away from the liver. In terms of hepatic veins, we have 3 of them. We have a right, a middle, and a left hepatic vein. So each one drains, a corresponding segment of the liver. So right lobe of the liver, middle hepatic vein splits the right and left lobes of the liver. We'll learn these vessels represent kind of demarcation between segments, and then left hepatic vein drains the left lobe of the liver. In terms of what that waveform looks like, the hepatic veins are pretty unique from other veins because they have a very pulsatile looking waveform that creates this distinctive W-shaped pattern where we see some systolic and diastolic components to it because they're in very close proximity now to the heart. So we have, again, diaphragm is going to be here, just again, the upper border of that liver. The hepatic veins drain into the IVC, the inferior vena cava, and we're very close now to the heart now, to that right atrium. We're getting very close to that heart. So you can see right hepatic vein draining the right side of the liver, middle hepatic vein, and then your left hepatic vein draining the left side or left lobe of the liver. So in ultrasound, this is what it's going to look like. Sometimes they refer to the hepatic veins as your bunny sign. So it kind of looks like a little bunny with the ears. So this is your larger IVC now, and the left hepatic vein, middle hepatic vein draining in. We're seeing a little piece of that right hepatic vein. So we're not seeing it all there in this picture. Sometimes it's hard to image all 3 in one shot. Sometimes we have to image them independently. When we get into actually assessing these and Dopplering these and doing a full, hepatic vein study or a portal vascular study, 3rd semester, we're going to utilize different techniques to acquire some of the images. So this was just showing a different approach, trying to get that right hepatic vein. So this is more of a sagittal view of the IVC with that right hepatic vein draining in. So this is your hepatic Doppler waveform. So it creates this W flow pattern, or it looks like these, it looks like a W. And it'll typically have a period where you get some reversal or change in flow direction. So this is normal. This is your normal hepatic vein waveform. So it looks very different from a lot of the other venous waveforms that you're going to encounter. So to be able to pick out and identify hepatic vein is important. So there's a systole, a diastole component to it. So we see a systole and a diastole waveform. And then the part that's above the baseline is actually when the atria contract and squeeze the blood out of the atrium. Some of that blood flow gets squeezed back down the inferior vena cava, and it causes a change in flow direction. So normally the blood flow again should be draining out of the liver into that IVC back up to the right atrium to the heart. So this is what's happening during systole diastole. But when the atria contract, that little bit of contraction squeeze the remaining blood flow out of the atrium, we get a little bit of flow reversal, push back down the IVC, and we see a change in that flow direction. So that's what's represented there. It's that atrial kick. Quickly name some vessels. Let's have a little fun. What do you guys think? Number one. Call it out. Shout it if you know it. Good, yeah. Celiac trunk, celiac axis, celiac artery. What about number 6? So this is not going out towards the patient left, so it's a branch of the celiac trunk. Putting you all on the spot. So 6 is going to be your splenic artery, going out to the patient left. Number 2 now, so here's celiac artery. Or we'll do number 4. So next branch off that anterior aorta, so coming down. This one arises anterior, it's the next branch below the celiac. Superior mesenteric artery, SMA, good. So if that's SMA, so just below SMA, we got one coming off to the left kidney now. Yeah, left renal artery. Before we said SMA, 3 is just abdominal aorta. Even though it's not labeled here, what's that guy? Superior mesenteric artery, good. So 7 now, another branch off that celiac artery. The other wing of that seagull.
The left gastric. Right gastric.
Common hepatic. So common hepatic artery. So that left gastric is gonna probably branch. So this looks like GDA or the gastroduodenal artery. Proper hepatic artery. Left gastric is gonna be kind of somewhere in here. It's not listed. I see it on the angiogram here. Yeah, so left gastric's not typically left gastric, I'm sorry, left gastric would be somewhere off here. Sorry, that would be right gastric, I apologize. Left gastric would be somewhere off the actual celiac trunk itself. Left gastric, again, is typically not seen on ultrasound. 5 is gonna be right renal artery. So this one you see coursing, again, posterior to the IVC going out to the kidney. 8 represents left renal vein now. So this is the left renal vein draining the left kidney, dumping into the IVC. So that's your left renal vein. In terms of the aorta and its bifurcations, it bifurcates first into the common iliac arteries. Common iliac arteries then branch into an internal iliac artery and external iliac artery. The external iliac artery will continue on down towards the legs, bringing blood flow to the legs. Internal iliac artery will feed your pelvic, some of your pelvic organs. Yeah, this is another good diagram for you to practice on labeling. So peripheral anatomy now. So now we're going to be talking about the distal arteries, the peripheral arteries going out to the arms and to the legs for the upper extremities and the lower extremities. So in terms of the arm, so when we're labeling stuff, we refer to the arm, we have different segments. So the upper portion would be your upper arm, we have our forearm, and the legs, we can have thigh, and then calf. Sometimes they refer to it as leg, the lower portion between the knee and the ankle as being the leg, but I personally would say calf. So this is coming from your textbook, but. So upper extremities. The main vessels that we're looking at for the arms, for the upper extremities, are going to be your subclavian, axillary, brachial, radial, and ulnar. Once we get down into the hand, we have palmar arches that supply blood flow to the digits. But we'll start from the top. We'll start with subclavian artery. So subclavian artery begins at the aortic arch on the left. So it's a direct branch off your aorta on the left side. On the patient's right, it's a branch or a bifurcation of the innominate artery or brachiocephalic artery. So innominate and brachiocephalic, again, vascular loves to have two names for everything. Well, not for everything, but that's one of the vessels that can have two names. So some literature you might see the brachiocephalic artery referred to as the innominate. Some textbooks call it the innominate artery, but that could be used interchangeable. So brachiocephalic or innominate artery. So the right subclavian artery originates from as a branch off of the brachiocephalic or innominate, and both of them will end at the thoracic outlet. The axillary artery is a continuation of the subclavian artery. So this is essentially the same vessel, the same artery. It's just changing name as we've changed anatomical area that we're in. So again, it starts subclavian artery. So think central subclavian artery coming across the anterior chest. So it's kind of running in this direction. Once we leave the thoracic outlet, so the clavicle and that first rib is your thoracic outlet, we get into the axillary now. So the axilla or the armpit is where that axillary artery resides. So it courses along the inner aspect of the arm from the thoracic outlet out to the teres major muscle. Again, it's just a continuation of that subclavian artery now. So we subclavian, axillary. That axillary artery, once we now get into the upper arm, now changes name. So now it's become the brachial artery. So same highway, same pathway, same vessel, just changing name now. So once we're now in the upper arm, it becomes the brachial artery. So they refer to it as a branch of the axillary, runs from the teres major muscle all the way down to the elbow. Typically the brachial artery doesn't split and bifurcate until you get past the bend in your elbow, past that antecubital fossa. So just in that proximal forearm is typically where most people it branches and splits. And then it splits into your radial and ulnar arteries. The radial artery will course along the lateral aspect of the forearm or the thumb side. So now this is when you have to be careful with anatomic position. So normal anatomic position is with the palms facing forward. So now you have to look at the body position, lateral and medial. So medial is more central or more midline. Lateral is going to be out towards the sides. So if I have normal anatomic position with my palms facing forward, along the thumb side is considered lateral on both sides. So that radial artery runs on the lateral aspect of the forearm, the thumb side. The ulnar artery is going to be on the medial aspect of the forearm on the pinky side. So I always remember pinky ulnar, PU. It stinks. So pinky ulnar along the medial aspect. There is another artery, the interosseous artery, which is a branch of the ulnar that kind of runs down the middle. It's not commonly imaged or visualized, but just so you know, it does exist. So you might encounter, you might be scanning the ulnar artery, you see a little branch come off, and you're like, oh, what's that? That could be the interosseous artery. In terms of the palmar arches, so we have two arches that exist within your hand that supply blood flow to the digits. These arches are connected to one another to allow for proper perfusion of the entire hand through both blood supplies. It's kind of nice. The body is amazing. It has these ingenious little fail safes. So if one of these vessels is diseased or bad, or if one of these arches are diseased or bad, we have a kind of a collateral pathway or an additional channel to supply blood flow to the entire hand via these two arches being connected. So the superficial palmar arch is a extension of the ulnar artery. The deep palmar arch is an extension of the radial artery. So this was just showing some of the anatomical makeup of the thoracic outlet. So some of the muscles that are involved. So this pectoralis minus muscle, the clavicle, and that first rib. So this is again that outlet in the chest. So we refer to this as thoracic outlet where the vessels exit out. So we're going to learn about a condition called thoracic outlet syndrome, where patients can wind up with compression of the artery or the vein or even the nerve, this brachial plexus nerve, in the thoracic outlet by the first rib and the clavicle and the muscle. And it could lead to potential disease or symptoms for that patient that suffer from this condition, thoracic outlet syndrome. So when people put themselves in different positions and moves, you can actually get compression of these vessels in those various positions. So that's a specific test that we do in the vascular lab, is to rule out thoracic outlet syndrome. We'll get into that a little bit later in the semester. So this was, yeah, a nice diagram just showing the arteries now. So this is the left side, showing, you know, that left subclavian, that branching off the aortic arch. Left subclavian becomes axillary artery becomes brachial artery. Brachial artery then branches into your radial and ulnar arteries, which then go down and feed your superficial and deep palmar arches. So deep palmar arch, extension of radial artery, superficial palmar arch, extension of the ulnar artery. So now this was showing on the right side now. So this is now the brachiocephalic artery coming off the aortic arch. And then that brachiocephalic artery then branches, you know, into your subclavian artery and your right common carotid artery. This is now in the patient's right. So brachiocephalic or innominate into your subclavian, into axillary, then into brachial, and then brachial into your radial and your ulnar arteries. I'm sorry, brachial into your radial and ulnar further down. Bless you. So in terms of arterial waveforms and what they look like. So peripheral arteries now a normal healthy peripheral artery should be triphasic, should be high resistance. So we see little to no diastolic flow. We see it go below the baseline, trying to get it back above. That one kind of doesn't. This one goes below and then back above again. This one definitely goes above. This one's multiphasic. It's going below, above it again. This is by someone that's very young. Nice, elastic, healthy arteries. But the thing you see in common, very fast upstroke, very fast downstroke, and then little to no diastolic flow. So this is a high resistant peripheral artery. So this is the characteristics that we expect to see. A very fast systolic upstroke, very fast downstroke, and then little to no diastolic flow. So these are all nice, healthy, high resistant peripheral arterial waveforms. So blood vessels going out to the extremities should be like this. And so it's in stark contrast to vessels going to organs or that organ flow. That organ arterial flow has lots of diastolic flow to it, very low resistant monophasic flow, in contrast to our peripheral arteries. This is just showing an angiogram where we could see again all the little branches coming off. So we had those main pathways and tributaries, but we do have additional small little branches and collaterals, other small vessels that do come off. I'm not expecting you to memorize any of these. The boards will never test you on all of these because we just frankly don't image them. They're either too small to image on ultrasound or they're in inaccessible areas. We oftentimes get a lot of lung interference that we're not able to see them. So again, don't worry about all these small little branches coming off. So this was an angiogram now showing the branching of the brachial artery. So this is an arm kind of in that position. You see the brachial artery coming down and then branching into your ulnar or radial. So this is probably the left arm. We're looking at it that way. Yep. So you have your radial and your ulnar artery. You can see the interosseous artery kind of running in between a branch off that ulnar. So ulnar, radial, brachial, coming down. And showing our nice palmar arches. and some of the smaller branches, that feed the digits of the hand. So we can have some anatomical variants, for the upper extremity arteries. One of the more common anatomic variants has to deal with the aortic arch itself and the great vessels. So it typically has to do with the origin of the brachiocephalic and the left common carotid arteries where they come off. So we can have different, anatomic orientations of that aortic arch. So, we might have a common vessel coming off the aortic arch, the left subclavian artery and the left common carotid artery might share a common branch or a common origin. Left subclavian could branch off the left common carotid, so we could have some variations in that. Variations in where the left vertebral arteries originate off. Typically, they should originate off the subclavians, but sometimes they come directly off the aorta. But you see the majority of them have to do with that. In the arm and the forearm, one of the more commons would be a early division of the brachial artery or a high origin of the radial artery. So last year we had Andrew, his radial artery was all the way up here, so it went all the way up the arm, up the forearm, up the rim, like his upper arm, and connected almost to his subclavian artery up here. So we were able to follow his radial artery all the way up, coming all the way up here. So he had a very high origin for his radial artery. Yeah, he was kind of, duplicated vessels like all over the place too. Specimen. We could see duplicated brachial arteries, another, fairly common anatomical variant. So patient having two brachial arteries. Ulnar artery from the brachial or axillary, so these are all things that you can encounter. So just be aware, not every patient's have your normal, vasculature. There are anatomical variants that do exist. So it can be a little bit tricky when you're scanning, especially early on. So here's an angiogram with an anatomical variant with that high radial artery. So here we can see brachial artery coming down. And then where we expect to branch into radial and ulnar, we just continuation of that vessel and it's just ulnar going down. And then if we started distally and picked up his radial artery, we could follow the radial artery, all the way down from the wrist, and it just keeps going, keeps going, keeps going, keeps going. All right, now we're in the upper arm, keeps going, keeps going, keeps going. So if you're ever in doubt and question, it's easier to start a little bit distally and try and track your vessels in reverse. Because again, all roads are eventually going to lead to home. All these arteries are eventually going to come together, form larger vessels, and eventually going to wind your way back up towards, the aorta or eventually the heart. This is just demonstrating, there are multiple collateral routes. So if patients do have disease and vessels are blocked, there are collateral routes that do exist and allow for, continued circulation. So upper extremity vessels. The one, subclavian, good. Then axillary, then brachial. Then two is going to be your radial, 4 your ulnar, it's along the pinky side. So 6 is distal to the ulnar artery, that's going to be your superficial palmar arch. 7 is distal to the radial artery, that's going to be your deep palmar arch. What's a good mnemonic? What's a good way for us to remember ulnar artery and superficial palmar arch? You? I think someone said pus like last year. Pinky, ulnar, superficial or palmar arch, pus, superficial palmar arch. I'm flying along, so you guys need to tell me if I'm talking too fast or slow down. I talk fast. So lower extremity arteries now. So we said aorta bifurcates into your common iliac arteries. The common iliac arteries will then split into internal and external iliac arteries. So again, two names for the other things. So you might see this somewhere along the lines when you're studying or getting ready for your board exams. Another name for the internal iliac arteries is going to be your hypogastric artery. You see hypogastric, you're thinking stomach. Why in God's name would they call that? The hypogastric artery. But another name for internal iliac artery is hypogastric artery. So common iliac arteries split into internal and external. Continuing down, so external iliac arteries are going to continue down towards the leg. Once we cross over the inguinal ligament, that external iliac artery becomes the common femoral artery. So you guys are gonna love my drawings. I'm the worst artist. All right, so we got a patient's leg. Up in the patient's groin area, we're gonna have the inguinal ligament. So there's a ligament that's in the inguinal canal up in the groin. Above or superior to that inguinal ligament, so if this is my artery coming down, above that inguinal ligament or superior to it, the vessel is the external iliac artery. So I'm just gonna abbreviate, EIA, external iliac artery. So it's that same vessel, kind of similar to arms. Once we get distal to or inferior to that inguinal ligament, we're still in the groin, that vessel now becomes the common femoral artery. So now it's the CFA, common femoral artery. So that inguinal ligament is kind of your demarcation zone between external iliac and common femoral artery. So external iliac is kind of in your lower pelvis, or you're at your abdominal aorta branching into your common iliacs around your belly button. Common iliacs then will quickly split into your internal and external. External is going to continue down, so you're still kind of in the lower pelvis. And then once you get past that inguinal ligament in the groin, that external iliac becomes common femoral artery, so CFA. A lot of arterial protocols will either begin with distal external iliac or common femoral artery as your first image. So you have to be able to kind of get there and recognize and know like where you are and where you're starting. That common femoral artery will then split into two vessels. It will split into your superficial femoral artery and your deep femoral artery. So deep femoral artery can also sometimes is called the profunda femoris artery. Again, two names. You might see this in two literatures. This is a little bit older nomenclature or name. More common or more likely you might see just referred to as the deep femoral artery or DFA. So SFA and DFA. So common femoral artery splits. We have our superficial femoral artery and our deep femoral artery. So this is now in the thigh. Give the guy a knee tap here so we know what I mean. Getting water on his knees. So we got SFA and then DFA, deep femoral artery. So that superficial femoral artery is really the one that we're most concerned about. This one continues down the thigh, all the way down the thigh, and eventually becomes the popliteal artery once we get to the level of the knee. So that's really the one that we image primarily when we're doing our lower extremity arterial studies. We do image DFA in that proximal segment where it splits, but it tends to run off lateral and deep and kind of around the leg when we lose it. So we really don't concern ourselves too much because that one really, it does have some connections back to SFA and maybe popliteal, but the SFA is the one that really brings the blood flow all the way down towards the foot to the smaller vessels. So we're really primarily focused on that SFA in terms of imaging. So DFA can provide some collateral pathways if it's if the SFA is obstructed, but the primary focus for us for ultrasound is going to be imaging that SFA, the superficial femoral artery. So once we get around the level of the knee, or when we get to the level of the knee, The SFA courses posterior immediately behind the knee and becomes the popliteal artery. So SFA, so similar to the arms, SFA now, once we get to the level of the knee, becomes popliteal artery. I'm just gonna kind of abbreviate pop art. Popliteal artery will then bifurcate and split. So once we get past the knee, it splits into two vessels. We have an anterior tibial artery, and then what's referred to as a tibial peroneal trunk. Your ATA. Okay. And trunk. So the anterior tibial artery, of course, is anterior along the lateral side of the leg, and eventually becomes a dorsalis pedis artery on the top of the foot, the dorsum of the foot. So it branches out lateral, of course, along the lateral anterior aspect of the leg, and goes all the way down to the top of the foot or dorsum of the foot, and becomes a dorsalis pedis artery. So on the top of the foot. So dorsalis pedis. My student last year insisted it was dorsal pedalis. Love you, Brian. So dorsalis pedis artery. So that tibial peroneal trunk now will give rise to your posterior tibial and peroneal arteries. So now we said popliteal artery splits into ATA, anterior tibial, and that tibial peroneal trunk. There's a short segment of that tibial peroneal trunk, and then it'll split into your posterior tibial and peroneal artery going down the calf. So this is now all in the calf. Posterior tibial artery is going to be in the medial calf. Posterior and posterior to the medial malleolus. So the medial malleolus is your inner ankle. So that's the term for your ankle bone, the medial malleolus. So if you kind of feel your ankle, it's going to terminate posterior or behind that medial malleolus. Particularly when we get into doing that exam, that's where one of the vessels we're going to be instigating and listening to do our exam is going to be finding this posterior tibial artery behind the medial malleolus, behind that inner ankle. And it forms the medial and lateral plantar artery. So when we get into vessels of the foot, we'll discuss that a little bit more. Peroneal artery, of course, is near the posterior aspect of the fibula, and then it's near the lateral malleolus. So this one actually terminates near the outer ankle, so anterior to that outer ankle. So we can actually pick up and Doppler peroneal artery if we needed to near that lateral ankle. And then we have plantar arteries and digital arteries down in the foot that we'll discuss later on in the semester. So in terms of these vessels, we have PTA, posterior tibial, posterior tibial artery, and then peroneal artery. Just to help you guys remember, the branching, ATA, anterior tibial artery, is going to be the most lateral vessel. So if you get board questions that ask you, vessel of the lower extremity in the calf, which is the most lateral, it's going to be ATA. So ATA, we put most lateral. Posterior tibial artery is going to be most medial. And then peroneal is kind of in between. So that's kind of how I drew it on like my little diagrams here. The most lateral one is going to be ATA, anterior tibial. Posterior tibial artery, most medial. Peroneal in between. Hey, anterior artery, most lateral. Posterior artery, most medial. Peroneal in between. Because the same is going to hold true for the veins as well. When you have to, on board exams and tests and quizzes, when you have to label these vessels, they'll say most lateral, most medial. Easy layup, give me a question. ATA most lateral, posterior tibial most medial, peroneal is gonna be in between. So you can kind of see it here too. So you got the patient's leg, posterior tibial, most medial, anterior tibial, most lateral, peroneal, they're in between. There was a nice picture showing that inguinal ligament now. So aorta, common iliac. So we got a small segment of common iliac, then quickly branches into your internal iliac artery and external iliac artery, which is continuing to bring blood flow down to the leg. Sorry. We cross that inguinal ligament now and becomes common femoral artery. So we got a short segment of common femoral artery. Common femoral artery will then split into your superficial femoral artery and then the deep femoral artery or that profunda. These are some additional small little branches that you might see when you're imaging. So things like the lateral circumflex, medial circumflex. So you could potentially see some of these as you're imaging. But again, we're just focused on those major pathways. That SFA, superficial femoral artery, continuing down the thigh. When you get to the level of the knee, becomes popliteal artery. That popliteal artery, so this is kind of looking the other way, becomes your anterior tibial. And then your tibial peroneal trunk. Tibial peroneal trunk then branches into your posterior tibial and peroneal. So extension of the anterior tibial artery becomes a dorsalis pedis artery. That dorsalis pedis artery again is another very important one for us because that's going to be another site where we're listening to and inseminating that vessel for the PVR SLP exam. So those are really the two real important ones for us when we're doing that test. Again, this is also, these vessels, when they become diseased, they really affect blood flow going to the foot, and particularly, when we diabetic patients, when they start having to, amputate and remove toes, it's these vessels that are very diseased, these distal ones that become very atherosclerotic, very narrow, that lead to poor perfusion. So, it's important for us to assess them. So there's a segment of the distal thigh that's referred to as the abductor canal. And in that abductor canal, within that abductor muscle, the vessels course. And I don't know why the boards like to ask. It's kind of like one of those like fun-filled Jeopardy questions. The most likely location for atherosclerotic plaque to develop is in that distal femoral artery in the abductor canal. So that's the vessel that seems to be most prone for developing atherosclerotic plaques. I don't know if it has to do with the pressure of the vessels within that compartment of muscle. So you'll see because of that thick musculature of the abductor canal and that distal calf, distal thigh, it makes imaging the vessel a little bit more challenging, a little bit harder. So the abductor canal is like that distal segment of the thigh there, where these vessels run. And is the most likely source or location for the development of atherosclerotic plaque in the femoral artery. Pretty sure we're going to talk about that again in subsequent weeks. Just some more detailed diagrams, showing a lot of the other additional branches that we have, collateral pathways and channels coming off some of these major vessels. So very similar to our upper extremities, lower extremity waveforms should be high resistant, triphasic, nice fast upstroke, fast downstroke, nice clear spectral windows. So this is a very nice tight spectral envelope. So these are all beautiful, nice, healthy looking Doppler waveforms. You look at your Doppler angles, they're lined up nice and parallel to the direction of the blood flow. So again, these are all, indicative of nice, healthy spectral Doppler waveforms. Excuse me. So this was just an angiogram showing some of the additional, branches that you might potentially see if you're scanning on ultrasound. So just recognize, there are other vessels that do come off and bifurcate. So some of the more common ones that you might see might be lateral circumflex, the medial circumflex artery. But again, we're focused more on the main channels in terms of imaging and what we're gonna be assessing with ultrasound. External iliac, common femoral, SFA, and DFA. And some more. So you can appreciate, just how complex the peripheral anatomy is with all these smaller little branch vessels. In terms of anatomical variants for the lower extremities, probably some of the more common ones are gonna be duplicated femoral arteries or maybe high bifurcation of the popliteal artery. You might have under development or aplasia of some of these smaller fat vessels. An anomalous location of the versalis pedis artery. This was just showing that, in instances where we have severe occlusion of these vessels, we do have a lot of collateral channels and routes to get around areas that are severely stenotic or occluded. So we're gonna learn how to look at some of these angiograms to appreciate what's going on. So with these angiograms, I said we have to use contrast agent to opacify or fill the vessel with contrast. So when you actually are able to visualize the vessel, that means that it's patent, there's contrast flowing through it. So areas here where it tends to get narrow, or in this case where we don't see a vessel segment, that means that there's no contrast that's been able to flow through that segment and that it's likely occluded or blocked. So some of this is getting filled in through some of these smaller collateral channels that are connecting into that vessel at that point and bringing contrast into that segments of vessels. What we're gonna do later in the semester, a little deeper dive into some of these additional imaging modalities. This is again some good practice, be able to label some of these vessels. For this first quiz coming up, this is what I'm expecting you guys to be able to label, the major vessels, the major branches here. Again, this would be good practice for you going from, be able to start, from, your brachiocephalic or innominate, subclavian, axillary, brachial, radial, ulnar. Coming off the aorta, common iliac, external iliac, internal iliac, common femoral, SFA, DFA, popliteal, anterior tibial artery, tibial peroneal trunk, posterior tibial peroneal. You have to be able to label dorsalis pedis on the top of the foot. And then the last little bit is our cerebrovascular or blood flow for our central nervous system, our intracranial system. So this is the blood supply bringing blood flow to our central nervous system, primarily our brain. The major pathways for blood flow to the brain are the extracranial or outside the cranium, the carotid artery, and the vertebral arteries. So there's actually two vessels that essentially bring blood flow up to the brain, the carotid artery and the vertebral arteries. And then we'll discuss a little bit some of the intracranial arteries, primarily the circle of Willis. So blood supply to the central nervous system. So we, like I said, we have the innominate artery or the brachiocephalic artery is that first major branch of the aortic arch. That brachiocephalic divides or bifurcates into your right common carotid artery and your right subclavian artery. So right subclavian artery is going out to the right arm. We're not worried about that in terms of cerebral vasculature, except for if there's disease in the very beginning part of it, but we'll discuss that a little bit. And then the right common carotid artery, which is bringing blood flow up to the brain. In terms of the aortic arch, the left common carotid artery should be the second major branch off that aortic arch. Both right and left carotid arteries branch into internal and external carotid arteries. So ICA stands for internal carotid artery. ECA stands for external carotid artery. And then the third branch off that aortic arch is the subclavian artery. So that's the third major branch off that aortic arch. So here's a nice diagram showing heart, our aortic arch, and our major branches. So here's left ventricle, proximal portion of the aortic arch, ascending aorta, aortic arch. First branch that we encounter is that innominate artery. Innominate artery will branch into your common carotid artery, right common carotid artery, right subclavian artery. So next branch is going to be your left common carotid artery. So we have right common carotid artery, left common carotid artery. That left common carotid artery branches directly off the aortic arch. And then third branch is your left subclavian artery. In terms of the common carotid arteries, they'll continue up the patient's neck. So they'll rise off the aortic arch, continue up the patient's neck, and eventually they're going to bifurcate or split into an internal carotid artery and an external carotid artery. So in terms of internal and external carotid arteries, you just have to be careful. So instinctively, I would look at this and be like, oh, that's external because it's outside. But the internal carotid artery is the one that continues up and brings blood flow to the brain. External carotid artery supplies the muscles of the face, some of the glands. So there's a superior thyroid artery, brings some blood flow to the thyroid gland, supplies a lot of the musculature of the face, the scalp. So ECA supplies the superficial structures of the face and the scalp and the head. Internal carotid artery, the ICA is the one that is the real one that we're concerned about because that's the main route for bringing blood flow up to the brain. So in this case, the ICA it's more lateral, but it's the one that goes up to the brain. So in this case, the left ICA going up to the brain, this is the right internal carotid artery going up to the brain. Another way that you can differentiate the two, if like I didn't have that brain in this picture, the ECA I'll always give you a picture that's got a little branch to it. So in the neck, the ECA has lots of little branches that come off of it that bring blood flow to different areas. So ECA, that external carotid artery, you can always identify it by seeing a branch here somewhere. The ICA doesn't have its first branch until you're actually in the brain itself. So ICA is a direct shot up to the brain. ICA, ECA. So those are your ECAs, and those are your ICAs bringing blood flow up to the brain. So we said there's two pathways. There's also the vertebral arteries. So the vertebral arteries are going to be your first branch off of each subclavian. So you have a right and left vertebral artery. So just like you have a right common carotid artery and a left common carotid artery, right internal carotid artery, left internal carotid artery, you also have a right vertebral artery and a left vertebral artery that also bring blood flow to the brain. So those are both branches and arise off the subclavian arteries, respectively. You have left subclavian artery. So this is still all left subclavian artery. And that first branch is going to be your left vertebral artery, bringing blood flow up to the brain. So you have your innominate right subclavian artery, and then your first branch off that is going to be your right vertebral artery, bringing blood flow up to the brain. So next semester, when we get into cerebrovascular ultrasound, we're really going to talk in depth about all of these vessels, the waveforms, the characteristics, the portions of the brain that they supply blood to. In cases of patients who are experiencing symptoms and stroke, the different symptoms that are associated to these different vessels and the pathways and territories that they feed. So this is a nice angiogram of the aortic arch, showing again those branches and those vessels. There's your ascending arch, descending aorta, innominate brachiocephalic, left subclavian, left subclavian, left common carotid. So in terms of the carotid artery. So the common carotid artery. So this is just some relational anatomy. It lies posterolateral to the thyroid glands. It's deep to the jugular vein. So jugular vein is typically anterior or above the carotid artery. And it's also deep to the sternocleidomastoid muscle. The common carotid artery. You won't see any sort of small little branches coming off of it. It'll only bifurcate or split into your internal and external carotid arteries. So you shouldn't see any small little branches coming off of it. It should be a nice straight vessel coming up the neck, and then you'll see the split into your internal and external carotid arteries. So the carotid artery just have a segment that's referred to as the carotid bulb. So this is an expanded portion where the vessel starts to dilate a little bit, just before the bifurcation. The reason that's important, that carotid bulb, is because it's a nice spot or a common spot for plaque formation to develop in the carotid artery system. So that's one of the common spots. So the bulb and the bifurcation are your two spots, your two money spots, where atherosclerosis and plaque starts to develop, and we get that narrowing of the vessel. Nice ultrasound image for a patient's common carotid artery. So it should be a nice, straight, uniform vessel. So you shouldn't see any areas where it starts dilating, getting big, until we get to that bulb section. And even the bulb, it dilates just slightly. So nice common carotid artery, free, clear plaque. We see no intraluminal echoes, nice and black within there. And then getting into the carotid bifurcation. So here's that CCA. So this is continuing up the neck. So just kind of anatomical orientation. This is the feet, that's the head. So this is proximal common carotid artery, getting more into mid, working our way towards distal common carotid artery. So it's continuation of that vessel. So distal common carotid artery. Now we're getting into the area where it dilates and gets bigger, your bulb, and then your bifurcation where it splits into your internal and external. So just on 2D grayscale ultrasound, it's a little difficult to tell which is internal and external. We would have to Doppler and listen to the vessels, or put our color box on to determine, the waveform characteristics. Because again, one is going to the brain. So if it's going to the brain, we expect nice low resistant flow pattern. And then one is going to supply the muscles of the face. So that's more external. So that should have a much higher resistant flow pattern. So internal carotid artery, it's typically the larger of the two and more lateral, the more lateral branch. So if I have my head turned and I'm coming up common carotid artery, the ICA is going to be typically more lateral, and the ECA is going to be more medial in towards the face. So lateral out towards the ear, medial kind of in towards the face. It supplies most of the anterior cerebrum. And again, it has no extracranial branches. So outside of the skull, you shouldn't see any sort of branches coming off that ICA. The ophthalmic artery is the first branch, and that's inside the skull, inside the brain, where we see that first branch, the ophthalmic artery, bringing blood flow out to the eye. Inside the skull, there are some other components. That ICA, we have a carotid siphon, where it creates this S churn, and then we get into the circle of Willis. Some of the branches of the anterior cerebral artery, middle cerebral artery, and then that posterior communicating artery. So we'll see that more when we look at the circle of Willis. So ECA now. So this is typically the smaller of the two branches, but again, don't let that be your ultimate guide as to which one is which and try to discern which is which. Because I've seen oftentimes that they're both very similar in size. I've even seen sometimes the ECA being a little bit bigger for whatever reason. Again, it's just the way that person is anatomically. But typically it's going to be more medial in relation towards the ICA, more towards the face, more medially, and slightly more anterior or anteriorly oriented. supplies blood flow to the neck, the scalp, the face. And with this vessel, it has multiple branches that we can see, particularly extracranial now. So these are all the branches coming off the ECA. So that first branch is gonna be your superior thyroid artery. So that's gonna be way down here, off right near the bifurcation. So oftentimes we utilize, that's why it's underlined, this superior thyroid artery to help us to identify the ECA, because we could sometimes see that branch coming off the ECA and off that vessel and be like, all right, I see a little branch coming off of it. That's gotta be the ECA. That's gotta be the superior thyroid artery that I'm seeing. So you can use that to help identify the vessel. Particularly if you're in a board exam or in a test situation, you see the bifurcation and one of the branches of that bifurcation has a little branch vessel coming off of it. That's gotta be your ECA. So you can use that to help identify. Some of the additional branches for the ECA are gonna be your ascending pharyngeal, lingual, occipital artery, facial artery. So the names of the vessels kind of give you where they're gonna be located, in terms of the face and the scalp and the head. So lingual artery going out towards the tongue, occipital arteries back towards the back of the head, the occiput. So the occipital bone is back here, facial artery, posterior auricular artery going towards the ear, maxillary artery towards the jaw. Superficial temporal artery is gonna be all the way up here in the temple, so it kind of runs all the way up. We get a branch coming up here towards our temple of our skull. The reason that one's also underlined is we can utilize it to help identify the ECA. So we'll see in a little bit later, there's a maneuver that we can perform that's called a temporal tap, where we put some slight oscillations and pressure on that temporal artery. We can actually pick that up on our spectral Doppler tracing to help identify the ECA. So in terms of Doppler characteristics between ECA and ICA, again, this talks about the size, the branches, the orientation. So this is our general, features to help identify. So the big things, are the resistance. Ultimately, if you're not sure, you're not definitively sure, Doppler it. ECA should be high resistance, ICA will be low resistance. We could perform, like I said, that temporal tap maneuver that we'll practice when we get into lab. We'll see oscillations on the ECA, well perceived. And then on the ICA, when we perform that temporal tap, we really won't see much of anything at all. So this was just kind of demonstrating now we're in transverse to that vessel and we're seeing the circles for ECA and ICA at the bifurcation. So in this case, this is kind of just going through the cardiac cycle. So the ICA, since it's going up to the brain, we should have continuous forward flow at all times. There should always be blood flow getting to that brain. So it maintains color throughout the entire cardiac cycle. Whereas with the ECA, we said it's higher resistance, so we might get a momentary period where there's no flow. That's okay, that's fine. So with our color box on, this one will always stay red. This one might flash black for a momentary period. Might even flash blue momentarily for a quick period. So that's another way we can differentiate and identify internal carotid artery versus external carotid artery. Here's our Doppler waveforms. So our ICA, nice low resistant flow pattern, lots of diastolic flow above that baseline, monophasic, always going in the one direction. Versus ECA. So with the ECA, there's much less diastolic flow. So if I look at this end diastolic velocity, it's much lower than what it is for the ICA. So if I just kind of was eyeballing it, so that's 50 there. That's maybe like 10 centimeters per second, maybe 8 centimeters per second. It looks like they put a number on the side. I don't know what they measure. Versus the ICA, this is like probably like 25, 30 centimeters per second. So it's much faster, much more significant diastolic flow for the ICA. So it's a much lower resistant waveform. For me, when I have to identify ECA, another thing that I look for is a deep dicrotic notch. ECA will typically have this very deep dicrotic notch. some patients, depending on their age of the patient, that dichrotic notch could even dip below the baseline. The ECA also tends to have look like very sharp peaks. So if I get a waveform and it looks like a tack, if I was to put my hand on there and it would hurt and spike me, it's probably the ECA. Versus the ICA is more of a rounded peak with this gradual runoff. So ECA, it's fast up, fast down, creating a very sharp peak and a very deep dichrotic notch. ICA, you get a fairly fast upstroke, but it's a gradual runoff. So it's blood flow going to the brain and then continuing to the brain. Nice forward flow, nice stream of flow. So this is an example again showing now that branch. So here we have that bifurcation. We see that bifurcation into two vessels, ECA and ICA. But hey, I see a little branch coming off that guy. So that's got to be our ECA because we're identifying a little branch coming off of it. So that's probably your superior thyroid artery coming off there. So the other vessel that brings blood flow to the brain is our vertebral artery. So we said these are the first branches off your subclavian artery. So you have a right and left vertebral artery coming off your right and left subclavian arteries. These supply the posterior part of the brain, the medulla, and the interior surface of the cerebellum. The right and left vertebral arteries will then converge and come together at the level of the pons to form the basilar artery. So the vertebral arteries are unique because they can also act as a collateral pathway or channel for the subclavian arteries, or the innominate artery if they happen to be occluded or diseased. So these vertebral arteries will actually act as a pathway to bring blood flow out to your arm if I have a central disease. So if I have a major blockage, here in the middle of my chest at the proximal portion of the subclavian or the innominate, and no blood flow is able to get out to my arms, the body will actually steal some blood flow from the vertebral artery to bring it out to the arm. So it's kind of a unique setup that the body does. That's particular to the vertebral arteries. So this was showing the vertebral arteries. So here's your subclavian, that vertebral artery. So the vertebral artery will actually, when you get, I want to say like mid-neck, proximate neck, it actually enters into a little frame, a little hole in one of the transverse processes of the spine and courses actually through the bone of the spine as it's working way up towards the brain. So we can actually see this on ultrasound. So there's a small segment, proximal segment that doesn't run through the spine. But as you work your way up a little bit, that subclavian, that vertebral artery actually courses through a foramen in the spine. Bless you. So we can actually see that on ultrasound as it's going in and out of that spine, the vertebrae. So here we see a segment of the vertebral artery, and when we get this shadowing is actually the bone of the spine. So we're not able to pick up the vessel or pick up any flow as it's coursing through that segment of vertebrae. So we can see artery, vertebrae, spinous process, vertebral artery, another spinous process, another vertebrae. So that's how we can help to identify, when you're imaging the vessel for this, your radiologist or the vascular surgeon, and we want to show the vertebral artery, I usually encourage you to image a segment where it's running through that spine so the doctor could see that and appreciate, like, yeah, all right, yes, this is definitely the vertebral artery that he's showing me. This was showing the segment of that vertebral artery as it's coming off the subclavian artery, where it's not running through, the vertebrae through one of those spinous processes. So going through, again, labeling your anatomy. So right now we're just learning the anatomy, learning the vessels. We're just going around, 5, you have your ascending aorta. 6 is the actual aortic arch. 2 is your descending aorta, descending thoracic aorta. 7 is going to be your brachiocephalic or innominate artery. 3 would be your right subclavian artery. I'm sorry, right vertebral artery. Apologize. 3 is right vertebral artery. one right common carotid artery, or well, it would be common carotid artery, sorry. One would be common carotid arteries. So 4 looks like your internal carotid arteries, then it's typically more lateral. We said the external carotid arteries are typically more medial. 3, left vertebral artery. 9, left clavine artery. I'm just gonna quickly go into a little bit, the intracranial arteries now, specifically the circle of Willis. So circle of Willis is a hexagonal arrangement of arteries composed of, the anterior, middle, and posterior cerebral arteries. And these vessels are joined by an anterior and, posterior communicating arteries. So this circle of Willis, when we get into cerebral vascular ultrasound and start learning about blood flow to the brain, is really an amazing structure because it helps to prevent, the development of stroke in patients. So having these collateral pathways and these collateral channels, really enables the body and the brain to survive, in patients that have severe arterial disease. So I mean, I've had plenty of patients, their ICA completely blocked, occluded, no blood flow getting in. They're coming in, walking, talking, singing, they're happy, no idea nothing's wrong, because of the circle of Willis, they're getting blood flow from the side that's still okay and blood flow getting through 2 portions of the brain that would typically be supplied by that side because of this circle of Willis. So this is the diagram, for the circle of Willis. Looks complex, looks complicated. Really not that bad, but we're gonna slowly break it down. So this is just some, introductory into circle of Willis. In terms of the circle of Willis, you kind of have to look at this as like you're a bird looking down on a patient's brain or skull. So look, if I took my skull and just like, took a blade, cut my head in half, and I look down on it, this is gonna be anterior. So these are your ophthalmic arteries. So if you wanted to, you could draw like 2 eyeballs here. And you're looking down on the patient's head from above. This is their eyes up here. So this is the front of their head, their eyes, their orbits. This is the back of the brain, the posterior circulatory system. So if I'm looking at a brain, like, cross-sectional slice, I was lying down on a table that way and I sliced my head that way. The eyes are gonna be up here. This is gonna be the back of the brain. So if you kind of get that in terms of your orientation, being able to label the vessels is a lot easier. So if my eyes are here, this is the anterior portion of my brain, my face. The vessels, so we'll start with internal carotid arteries. So we have the internal carotid arteries on each side. So right internal carotid artery, left internal carotid artery. They're coming up, up the neck, into the brain, into the skull, into the brain. That ICA does a little loop. That's referred to as the carotid siphon. That's where we see that first branch of that ICA is that ophthalmic artery that we said. So first branch of the ICA is your ophthalmic artery. It's down here. Yeah, there you go. Ophthalmic artery. Goes around that loop, the carotid siphon, and then splits into your anterior cerebral artery and middle cerebral artery. So that middle anterior cerebral artery feeds the anterior portion of your brain. Middle cerebral artery feeds, a large territory for the lateral aspects of the brain. So that's the anterior circulatory pathway. So ICA supplies the anterior and middle portions of your brain. You have your middle cerebral artery going outwards, supplying the mid portion of the brain, anterior portion of the brain, and then posterior portion of the brain. So if this is anterior, this is gonna be posterior now. So we do have these communicating arteries, which are very important and vital, and these are really what allow blood flow to get to any portion of the brain are these communicating arteries. So there are 3 communicating arteries that exist. We have 2 posterior communicating arteries, one on each side, a right and a left posterior communicating artery. And then we have a single anterior communicating artery. So this is your right anterior cerebral artery, your left anterior cerebral artery, and then a little communicating artery in between the two that connects the two anterior cerebral arteries. So this anterior communicating artery connects right brain circulation with left brain circulation. So if I have an issue and this carotid artery patient's got disease down here, very little blood flow or no blood flow getting to this part of the brain, the body says, oh God, I need to do something. It's gonna open up this communicating artery and allow blood flow to get from this side over into this side now. So typically the disease is gonna be somewhere in the neck, somewhere again, the bolt bifurcation down in the neck. These pathways are still okay. There's still not gonna be any atherosclerotic plaque in there typically. That channel will open up and allow blood flow to flow from this side across into these pathways and fill these vessels and bring blood flow to that side of the brain where it needs to go. In addition to that, if we have disease in this ICA, we have this posterior communicating artery. So this connects anterior circulatory pathways or channels and systems. So think of this as almost like two different systems operating simultaneously at the same time to bring blood flow to your brain, all parts of your brain. So we have the vertebral arteries also bring blood flow up. Vertebral arteries, right and left, come together, form basilar artery. Basilar artery then splits into posterior to your right and left posterior cerebral arteries. So those posterior communicating arteries will connect this pathway with this pathway. So again, if this is disease, nothing going on over here, we can bring blood flow from the opposite side, or we can still get some blood flow from the vertebral artery on that same side. Bring blood flow up that way and try and fill those channels. So ideally, both would happen at the same time, to ensure adequate perfusion. So in terms of the posterior circulatory system, we have, again, right and left vertebral arteries coming up. They eventually, in the brain, once we get to the level of the pons, they come together, form the basilar artery. That basilar artery then splits into right and left posterior cerebral arteries. And then posterior communicating arteries are right and the left, connect the anterior and posterior circulatory pathways. Next semester, we're going to be going all over this. We're going to do transcranial Doppler, flow directions, what's going on, collateral pathways. So this is just kind of a little dive into it in terms of like the anatomy and the structures. So
what? Are the communicating arteries not normally open and circulating if there isn't like absence of disease in the, or do they normally have blood flow through them?
they normally do have some blood flow. Anterior, not usually. Posterior, usually flow direction is from the ICA into the posterior. There's a little bit of flow direction in this direction. The pressures are a little bit higher in the ICA. So just for normal pressure gradients, it forces a little bit of blood flow in there. So when we do our transcranial Doppler, if we see flow going in this direction, we know that that's probably an issue, or there is an issue going on somewhere in here. Because normal flow direction should be in this direction, but if we see it going this way, then that's one of the things we'll look for when we do transcranial Doppler. Same thing with anterior cerebral artery. So if I see, if I'm doing my, if I'm going from this side, I expect blood flow in the anterior cerebral artery to be going this way, like away from me. But if I see blood flow coming in this direction, I know it's coming from this side across and down, that there's an issue somewhere here that's not, filling those territories. So flow direction is very important when we get into transcranial Doppler. So we're going to discuss all that. Definitely flow direction, it's collateral channels. But don't worry about that right now. Don't worry about flow direction, please. Yeah, that's what board's question will ask you. You'd be like, patient is performing transcranial Doppler through the left, transtemporal window. Flow direction in the left anterior cerebral artery is towards the transducer. This indicates, oh dear gosh. So you're gonna have to like break it apart and understand it. And we'll get there. So don't worry. Talk fast today.
For the patient that you were using as an example that would come in and have blood flow coming from the other side,
Mhm.
of the brain. What do they present with? Like, what would their symptoms
Yeah,
vary or?
yeah, it would vary.
Like you were saying, like, they really don't kind of.
Yeah, I mean, they might be complaining, I mean, it could be anything from just dizziness to
Right.
syncope, collapse, loss of
Right.
consciousness. They might have some of those stroke symptoms that might have been just transient, you know, like
Right.
they might have all of a sudden, their speech didn't make sense, you know, aphasia, dysphagia, right-sided numbness, right-sided tingling, or depending on which side's affected, you know, we could have disease in the vertebral arteries and somewhere going on back there, and then those patients would have more things, symptoms like imbalance, so uncoordinated muscle movements, vertigo, it's another big one. So these are all different, you know, cerebrovascular symptoms that we're gonna learn about. I'm telling you, you guys are gonna be like little doctors diagnosing these people. Questions, anything?
So if you were us, if you're me, coming from this as like an absolute overload of information, just dealing with anatomy and like everything. Terms I'm not familiar with, so how would you go about just kind of,
Trying to study right now,
yeah, like chipping away at what's most
Yeah.
important and then. I know it's all important, but. yeah.
definitely knowing, labeling your vessels. Like, I want you guys to be able to label your vessels. Our first quiz is gonna have some labeling on it. I'm gonna have some of these nice little pictures on there, like I like that one, you know, be able to label your vessels, the major vessels. So right now, it's about you guys learning your anatomy, learning your vessels, learning the waveform characteristics, you know, what a normal peripheral arterial waveform should look like, what a normal renal artery waveform should look like, you know, high resistance, low resistance. You know, being able to identify a hepatic vein waveform, being able to identify, you know, your aortic waveforms above and below, you know, how they're different. I think what else asked. Into Venus. So from last lecture, you know, transmural pressure, hydrostatic pressure, um, Poiseuille's, the variables, how they're like, you know, be able to write out Poiseuille's equation and like, you know, the different variables and how they're related. If this goes up, this would have to go down to maintain a constant flow volume, the relationships in that. Day before the quiz, we'll do a little review, what I expect, so. I know it's a lot. Everyone tells me it's a lot.
It's a, it's a.
It's a lot. It is. The good first step is being able to go home and try and label the vessels. So for right now, we did arterial. So next week we're gonna do venous. Be able to label your arteries, you know, off your aorta.